Welcome to The Code Tray, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
So to kick us off for our research hour, we have Abigail Hall, a PGY2 emergency medicine resident at Tallahassee Memorial Healthcare, who will be presenting on evaluation of olanzapine in the management of cannabinoid hyperemesis syndrome in the emergency department.
I nor any of my co-investigators have anything to disclose for this presentation. So just to start with some background information, so cannabis use in the U.S. has increased with recent changes in legalization and decriminalization. So as of March of 2026, currently 40 states allow for medicinal use of marijuana and 26 states allow for recreational use. So after being first described in 2004, cannabinoid hyperemesis syndrome has been receiving increasing recognition amongst our U.S. emergency departments. Therein, we're seeing a clinical and economic burden due to the increased ED visits, hospitalizations, as well as advanced diagnostic testing often associated with these patients' presentation. So CHS is a subtype of cyclical vomiting syndrome, or CVS, and it's associated with the chronic and heavy use of cannabis. And in 2024, the American Gastrointestinal Association guidelines proposed updates to the 2016 Rome 4 clinical diagnostic criteria for CHS, including episodic vomiting resembling that of CVS in terms of its onset, duration, and frequency, chronic and frequent cannabis use patterns, and resolution with cannabis cessation for at least 6 months. They also note a supportive indicator could be patient-reported prolonged hot baths or showers. So as of current, diagnosis and management of CHS remain a challenge amongst our emergency departments, and this is due to there not being any definitive testing available and limited high-quality evidence for treatment options. So current guidance suggests that goals of therapy for patients presenting to the ED with symptoms suggesting CHS include rehydration, correction of electrolyte abnormalities, and symptom relief. However, for symptom relief, traditional antiemetics have been proven ineffective as monotherapy. And there is limited evidence that exists for symptomatic management. However, what is listed include topical capsaicin, benzodiazepines, haloperidol and droperidol, promethazine, olanzapine, and ondansetron. So for current guidance, it's recommended to use a dopaminergic agent for symptomatic treatment as a first-line agent. So I did want to review some relevant literature here. So haloperidol, in 2020, the HAVOC trial was published, which was a triple-blind randomized crossover study, and it concluded that IV haloperidol was found to be superior to that of ondansetron as a first-line agent in reducing abdominal pain and nausea in cannabinoid hyperemesis syndrome. And then looking at some literature around droperidol, in 2019, a retrospective review was published, and they concluded that the use of droperidol should be considered due to its findings suggesting shorter lengths of stay, as well as decreased administration of additional antiemetics. And in 2024, a prospective multi-center open-label study was published, and they concluded that droperidol, in addition to diphenhydramine, is safe and effective in CHS symptom relief, symptoms including nausea, vomiting, and abdominal pain. So given the antipsychotic with dopaminergic activity recommendations, I wanted to look at olanzapine more specifically, which is one of our atypical antipsychotic agents, which has dopamine 2, serotonin 3, and histamine 1 receptor antagonist activity. Some dose-dependent adverse effects include sedation, extrapyramidal symptoms, and anticholinergic effects. Current evidence is limited for the use of olanzapine in cannabinoid hyperemesis syndrome. However, in 2021, there was a case series published which concluded that adequate symptom resolution was reported amongst these cases when utilizing oral olanzapine doses ranging from 5 to 20 milligrams following inadequate relief from initial traditional antiemetic therapy. However, unknown efficacy of other routes of administration, including intravenous or intramuscular routes in CHS, currently exists for olanzapine. So for the purpose of our study, it's to determine if administration of olanzapine within the emergency department is effective for treatment of cannabinoid hyperemesis syndrome. Our study will be a single-center retrospective observational cohort study in which we'll collect patients from April 2025 to April 1st of 2026 at our Tallahassee Memorial Healthcare Emergency Centers, inclusive of our Bixler Trauma and Emergency Center, as well as our Northeast Emergency Center. Our study cohorts will include a standard of care group. So we define standard of care as those receiving rehydration, electrolyte replacement, as well as antiemetic therapy for symptomatic management. And then in our cohort 2, it will be inclusive of our standard of care as just stated, in addition to olanzapine. For our study endpoints, we're going to evaluate our primary endpoint being length of stay, and our secondary endpoint being the amount of antiemetics received during ED encounters. For our inclusion and exclusion criteria, we're going to include patients 18 years or older and have a diagnosis of cannabinoid hyperemesis syndrome with the following ICD-10 codes. And then we're excluding patients with a known hypersensitivity to olanzapine, currently pregnant or breastfeeding, following ED encounter, prolonged QTC at baseline being males greater than 440 milliseconds and females greater than 450 milliseconds, and then excluding patients with a systolic blood pressure less than 90 initially or a MAP less than 65 at presentation. So we do have some patients that we've collected thus far, so we are going to present some preliminary results. So looking at the patients that we've screened a total of 68 and included 50 of those patients. We've excluded 18 based on prolonged QTC at baseline, admission following ED encounter, and then one patient being currently pregnant. So just to review our current baseline characteristics, so median age being 23 for all patients. The current patient population is primarily female at 62% for a patient population. However, in our standard of care, in addition to olanzapine, we see that less than 50% compared to that of our standard of care alone group. For patients reporting a history of CHS or a documented history of CHS, a total of 62% of patients have a history of cannabinoid hyperemesis syndrome. However, we do see variances amongst our standard of care and standard of care plus olanzapine group, with 48.3% in standard of care and 81% in our standard of care with olanzapine group. We also noted abdominal pain reported in the chief complaint of patient presentation, which was a total of 70% amongst our patients. And then we evaluated an abdominal pain score using a numerical ranking scale reported at ED arrival. And severe abdominal pain was defined as a numerical ranking score of 7 to 10. And amongst those patients reporting abdominal pain, there were a total of 54.3% with severe abdominal pain, which was consistent amongst both groups as well. And then also patients receiving IV fluids, there was a total of 84% of our patients that received that in ED admission. So just looking at some numbers for our primary endpoint, which was median ED length of stay. For our standard of care group, it's 5.15 hours, and then our standard of care plus olanzapine group is 5.62 hours. We're not computing this data as of current, but here I have listed the median as well as ranges of time for ED length of stay. And then for our secondary endpoint, which is antiemetic doses received through their total ED encounter reported as a mean. It's 2 for both our standard of care and standard of care in addition to olanzapine group, with ranges listed here as well. And just to discuss our study direction, so we're not going to provide any study conclusions at this time until all available data is collected and analyzed. However, we would like to perform further analysis on our data that's collected and evaluate time of antipsychotic agent administration to ED time of discharge to compare times between those, and then suggesting future large multi-center studies being directed to compare antipsychotic agent administration for symptom relief in cannabinoid hyperemesis syndrome to contribute to current available literature. And then given that this is a retrospective chart review, I did want to discuss some of our study limitations thus far. So we're seeing limitations through appropriate documentation, medication administration timing, and then prescribing differences amongst our providers. And that is all I have on the olanzapine and the management of cannabinoid hyperemesis syndrome, and I'll gladly take questions at the appropriate time.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.